So we're in an emerging targets and emerging therapy section of this discussion. Let's think about whether the dose of carfilzomib being at 56 milligrams per meter squared counts as a new drug. So we'll discuss that, I think, in this session a little bit. There was data on the Endeavor trial, which was looking at 56 milligrams per meter squared. Rafael, can you talk us through that presentation?
Of course, happy to. I'd like to say I think the Endeavor clinical trial is one of the most important abstracts that is being presented at this meeting. And again, just recognizing the courage of the company was a head-to-head comparison between bortezomib and carfilzomib. And it's a very large study. It's a 929 patient study, a phase 3 clinical trial. 464 patients were treated with KD, 465 with VD. This is patients with 1 to 3 prior lines of therapy. The primary endpoint was progression-free survival, and the study met its primary endpoint. Patients were treated in a traditional schedule for bortezomib. For carfilzomib, there was a slight change in that the dose was augmented for the higher dose portion of treatment to 56 milligrams per square meter. So this is higher than traditionally we use or what's available in the package insert. The differences in overall survival are clinically very important. So we see a difference of 18.7 versus 9.4 months for the carfilzomib versus the bortezomib.
Progression-free survival.
Progression-free survival, correct. And the data for overall survival still is immature. The subset analysis, the data suggests obviously that this is something that affects all patient subgroups, including patients who had prior exposure to bortezomib, appears still to come ahead in this particular clinical trial. Obviously, we have to wait for the final publication. But all of this being confirmed would suggest that actually carfilzomib is a superior proteasome inhibitor, at least when it comes down to anti-tumor activity. I think it's important to recognize that when the Aspire data was presented, a lot of the concerns regarding the toxicity of carfilzomib were allayed, and I think we understand them better. They are there. There's an issue, for instance, with increasing in cardiac toxicity, but the absolute numbers are pretty small. I think it's fair to say that for the majority of patients, this is a safe drug. So it's really remarkable because it sort of raises a question: how do we move into the future when we think about proteasomal inhibition in the setting of myeloma therapy?
Okay. So reactions to that, reactions to the Endeavor data from the group. 56, is that the right dose?
I think that we've done a trial as well with we've published on a large cohort of patients who got 56 milligrams per meter square, and although indeed there were more cardiac toxicity, it salvaged a lot of patients, and patients are still on 56 milligrams per meter square upwards of 2 years, even in the single agent setting. So I think that it is a very active drug.
I think it's practice changing. I think both in terms of the superior outcomes and of course the neurotoxicity issue. So I think it's going to have a real impact in the community.
Jatin?
So Sagar, I want to take a step back and reset that conversation. And so I think the question is not, and I think the interpretation of the data should not be that we're doubling the dose of carfilzomib and therefore we get higher response rates. And I think that's wrong interpretation. Or to say that we're giving a high dose of carfilzomib or a super high dose is not the appropriate interpretation of the data. And in fact, what I would argue, and we'll see this in the Champion data as well, but what essentially we've done now is establish that carfilzomib 56 milligrams per meter squared given with steroids is full dose carfilzomib. And that we know that when we combine drugs with other drugs, then we're going to have to lower the dose of therapy. As you go into later lines of therapy, you're going to have to dose reduce therapies, and that's normal and expected. So when you look at carfilzomib 27 in later lines of therapy in 4, 5, and 6, I think that's normal to use reduced dose carfilzomib in that setting. But in fact, we should redefine that full dose carfilzomib. And this is what we've seen, for example, when we looked at RVD. When we looked at RVD in newly diagnosed patients, we were able to combine full dose RVD with Revlimid 25 and full dose bortezomib 1.3 milligrams stage 1, 4, 8, and 11. When we looked at the same combination in the relapse setting, the MTD was actually 1 milligram per meter squared. I'm sorry, 1 milligram per meter squared of bortezomib and 15 of lenalidomide. And so it's not. So I think that principle of, using when you use combination therapies in later lines, you're going to have to reduce the dose, I think is an accepted kind of concept. And so we should reset the conversation with carfilzomib being 56, not being a high dose or doubling the dose. It's really, in fact, full dose carfilzomib. And then when you combine it, you have to use lower doses. For example, with lenalidomide, you can use 36 milligrams. Or if you go in later lines of therapy, when you have less bone marrow reserve, you're going to use lower doses of len. You're going to use POM 2 milligrams. You're going to use lower dose of CAR, and that's normal. So I think that that's an important kind of subtle difference to kind of reset the conversation when we talk about carfilzomib dosing.
There is one caveat to this that's important for the practicing clinician in the community, is that 56 milligrams per meter square has to be given over 30 minutes rather than
Correct.
10 minutes. And that really made a big difference in terms of tolerability. So the package label says 2027 over 10 minutes because over 10 minutes that was the MTD,
Sure.
if you will. But
And the other subtle point is you can increase the dose not on starting cycle 2, day 1, but on cycle 1, day 8.
Sure.
So you can do 20 milligrams per meter squared in cycle 1, day 1, but then quickly escalate after that. Now there's 2 other studies that are upcoming, which I think are going to be important. And so if the Champion study, if I can quickly comment on that, looked at weekly carfilzomib. So they dose escalated carfilzomib in patients with 1 to 3 lines of prior therapy, so earlier lines of therapy. And they went up to 70 milligrams per meter squared given over 30 minutes. And we saw some nice response there, rates of 72% in that setting, and a progression-free survival of 10 months. Now it's important because half of those patients were in fact bortezomib refractory, so we can't compare this to Endeavor data because the Endeavor, most of those patients were bortezomib sensitive or naive. So, but in fact now we can show that weekly we can do higher doses of carfilzomib, and again with nice response rates. But the key for this is going to be, I think, 2 upcoming phase 3 studies. And one is going to look at carfilzomib 27 twice weekly versus carfilzomib 70 once weekly. And the other one is carfilzomib 27 twice weekly versus 56 twice weekly. Because I think what we want to understand is what's the increased cardiac toxicity or renal toxicity, or is there none? And what is the incremental benefit in that earlier lines of therapy? Because I think that's the other key, that yes, we can do it at those full dose of therapy, but is there any changes in side effects or toxicity?
Yeah, I mean, I think that's a great discussion, and I think that's why I count it as a new drug, because if you give it once a week or you give what may be the correct dose, it may behave like a different drug than what we're traditionally exposed to. So let's wrap up just talking a little bit about emerging drugs or emerging targets that people are excited about. What's out there? We've talked about antibodies, we've talked about proteasome inhibitors, we've talked about IMiDs. What's out there that may be new targets or new classes that people are excited about?
Well, although it's a proteasome inhibitor, I'm very excited about oral proteasome inhibitors. Ixazomib has been combined both with cyclophosphamide dex and lenalidomide dex. And although proteasome inhibitors really have been a real breakthrough for myeloma patients, the scheduling is still a challenge. Having to come in every week for 9 months as an example. And being able to take 1 pill fixed dose, 4 milligrams once a week, I think has a real impact on the quality of life that patients have, that they don't have to be tethered and they can be traveling, which is a real issue for patients. And so being able to take an oral proteasome inhibitor, ixazomib has been studied more, but there's no question that other oral proteasome inhibitors are being developed in a twice-weekly schedule. Offering all oral therapy, I think, is going to be very important for our patient population.
And just to highlight Shah's data that he presented at ASH, ixazomib given as maintenance therapy even has a deepening of the response.
Okay, other targets people are excited about?
You know, I mean, we'll briefly mention other targeted therapeutics such as selinexor, which is, deals with the pumping out of tumor suppressor genes and the inhibition of that. I think we'll see probably other opportunities that come through genomic knowledge, but I would say that all in all, what we just said about the monoclonals is probably the most exciting set of agents for the treatment of multiple myeloma right now. I'm going to sort of keep a watchful eye on checkpoint inhibitors To what extent they're going to be as beneficial in heme malignancies as they are in other tumors, we don't know yet. But I think we have plenty of work to do right now with the current monoclonals that we discussed.
Jatin, you've done a lot of work with the Ray 520. What do you?
Yes, I think that's another important target as well, flunaceib. I mean, I think at the end of the day, we have good single-agent activity with flunaceib in patients that are refractory to Velcade and bortezomib and lenalidomide, and even some data with carfilzomib and pomalidomide now. So there's some good single-agent activity with that combination with dexamethasone. And we've combined it with carfilzomib very safely, and I think showing that we can actually synergize nicely and potentially improve response rates beyond that as well. So I think there's some nice opportunities there as we move forward. I don't want to lose sight of that. I mean, I think we have lots of excitement with immunotherapy and monoclonals. I think these small molecules, including selinexor or flunaceib or dinaciclib, a CDK inhibitor, I think there's still going to be a role for those drugs at the end of the day, because until we cure patients, patients still need therapy. And so that's the hope and the goal. But I think we have to continue to be aggressive looking at all these therapies and not be intimidated by the antibodies.